Yeah, live, please.
So, good evening, postgraduate, and my regards to all the mentors who are present for this today's webinar. Well, this is the 135th episode of All India Online Postgraduate Teaching Program, which is an initiative from AIOS ARC team. Well, we started this initiative during our last tenure, and we are continuing in our second tenure as well, with few new faces in our team of ARC. Well, today's program has been conceived, designed, and rather created totally by our two members from ARC team. One is ARC member center, that is Professor Dr. Deepak Mishra, and ARC member is Dr. Bibhuti Kashyap. I'm really thankful to them for conceiving such a wonderful program, and I'm sure the postgraduates are going to benefit from this program, how to get initiated into cataract surgery. So, without much ado, I would request today's anchors, Dr. Bibhuti and Dr. Deepak Mishra, to invite all the guests, faculties, and the discussants and continue with the program. Over to you, Bibhuti.
Thank you so much, Prashant sir, and good evening to one and all. So, welcome to this ARC webinar on didactic lecture on cataract. So, this talk is primarily aimed at postgraduates for having an overview about what and how a cataract is seen, diagnosed, planned, operated, and taken care of. So this talk has been divided into four categories. The category one will be classification and clinical examination, then going on to investigations in cataract, going on to management of cataract, and then followed by discussions on complications of cataract surgery. So without further much ado, I'm gonna start with the first segment. For the first segment of classification and clinical examination, we have with us Dr. Harshita Saxena and Dr. Jagdish Rana sir. So just a brief introduction of Dr. Harshita, who's going to be the first speaker. She is an anterior segment and cornea specialist, completed long-term fellowship in cornea and anterior segment from CL Gupta Eye Institute, affiliated with LV Prasad, actively involved in managing corneal diseases and performing cataract and anterior segment surgeries with a special interest in ocular surface disorders in Netralaya Super Specialty Eye Hospital, Ahmedabad. Along with her, we have Dr. Jagdish Rana sir. I don't think he needs any introduction, but just for the unversed, he is a phaco and laser eye surgeon, director at Parth Eye Hospital, Ahmedabad, a very well-known figure amongst ophthalmologists across India and especially in Gujarat. So I hand over the talk to Dr. Harshita Saxena to go first. She'll be presenting for 8 minutes, followed by discussion from Dr. Jagdish Rana sir for 3 minutes. Over to you, Dr. Harshita.
Yes, sir. Thank you, sir. Good evening, all the faculty members and the PG trainees. So, thank you, first of all, AIOS and ARC for giving me this platform to speak on the topic classification and clinical examination of cataract. So, to start with, in this lecture, I'll be discussing about the anatomy of the crystalline lens and the definition. We'll be giving the classification of cataract. We'll outline the clinical feature and clinical examination methods, and also will highlight the importance of early diagnosis and management of cataract. So to define the cataract, as we all know, it's a pathological loss of transparency or opacification of the crystalline lens that occurs due to degeneration or opacification of native lens fiber, formation of aberrant and malformed lens fibers, abnormal depositions of material within the lens structure. As this term, waterfall illusion, you would have heard before. This was actually until mid 1700s widely believed by the physician that an opaque material flowed like a water into the eye to obscure the vision. So this term originated from there. So now, as we all know, cataract is one of the leading cause for blindness worldwide. And in India, the prevalence is around 14.9 per thousand individual. And it alone accounts for around 62.6% of the total blindness burden of all the causes. But recent data shows that there is a 25% decrease in the blindness prevalence in India due to largely by the improvement in the surgical intervention. So to describe the anatomy of the crystalline lens, as you all know, it's a biconvex avascular transparent structure, and it is located in the patellar fossa between the iris and the vitreous. The components include the capsule, epithelium, cortex, nucleus, and which is suspended by the zonules. So the capsule is a thin, transparent hyaline membrane secreting the outer boundary. Then the cortex is a concentric sheets of younger active lens fibers surrounding the core, and the nucleus is more of dense central core containing the oldest, most compressed fibers. So to describe the physiology, as we all know, the physiology of the lens is to maintain the transparency that is maintained by via ordered lens fibers. And due to its nature of maintaining dehydration state, crystalline proteins acts to maintain all these functions. And the function is to provide the reflection, that is refractive power of 18 diopters, and accommodation. So to understand the physiology, these ordered lens fibers, which are highly specific in orientation. So these fibers forms a precise diffraction grating. So that induces a destructive interference, minimizes the stray light scatter, and mature fibers also degrade their organelles to maintain the clear optical pathway. That's how this first mechanism of structural interference help in the maintenance of the diffraction of the light. Then comes the chaperone system. That is 90% of the lens proteins are water-soluble, crystal, alpha-crystalline, as we all know, complex, act as a molecular chaperone. So the dynamic structural nature actively suppresses the aggregation of the lens fiber and proteins that become denatured by the high heat. These are all the stress factors that leads to denaturation of the proteins, and subsequently the chaperone system fails and leading to the irreversible protein aggregation, massive light scatter, and visual opacity. So to describe a little bit of an embryonic development of the lens, as we know, on the day 27, the surface ectoderms that forms the this thickens up, and the optical vesicle thickens up into the columnar cells to form the placard. Then subsequently, there occurs a focal indentation that forms the inferior to the center of the lens plate, and this bit deepens up, and the stalk of the cells connecting to the ectoderm begins to constrict. And subsequently, on the 33rd day, the stalk disappears entirely and leaving perfectly formed isolated sphere. So there are different types of fibers, as we know: primary lens fiber, secondary lens fibers, and the capsule formation. So primary lens fibers is basically epithelial cells elongate and anteriorly and fills the cavity that forms the embryonic nucleus. Secondary lens fibers have two aspects: anterior aspects of fiber and the posterior aspects of fiber. So anterior aspect of fiber forms the anterior pole, and the posterior ones form the posterior pole of the lens. Capsule is basically formed from the basement membrane secreted by the lens epithelium. This is the thickest basement membrane in the body. To describe the etiological based classification of the cataract, so the most common one is age-related, congenital, systemic, metabolic, like due to diabetes and hypocalcemia and other metabolic diseases. Toxic one includes the most common drug which is involved is corticosteroid and other drugs like long-acting miotics. Traumatic is due to trauma, as you all know. Then the most commonly seen cataract is rosette shaped cortical cataract, and the secondary one is due to complicated other diseases. So that will be discussed later. So now to describe the morphological classification, that is nucleus, cortical, and subcapsular. I'll be describing this in the subsequent slides. So nucleus sclerosis is basically a central nucleus involvement. So that is basically the nucleus becomes thickened up, and it changes the color, yellow to brown discoloration, that leads to myopic shifting. In cortical cataract, there is a spoke-like opacity. Opacities appear and begins in the peripheral cortex. So glare and difficulty in night vision is the most common symptoms which we see in these type of cataract. Then comes the posterior subcapsular cataract, that is opacity near the posterior capsule. Disproportionate visual loss, difficulty in near vision, and glare are the common symptoms. Then these are how the progression of the senile cataract occurs. This is also one of the type of grading or the classification we see. That's how we grade. That is immature. That comes as a lens is partially opaque, but the section remains clear. Swelling or intumescent stage may occur in this stage. Then comes the mature. The entire lens architecture become completely opacified. Then the hypermature, where the degenerative breakdown can present as a sclerotic shrunken capsule, or the Morganian, that is a other stage. That is in this, basically the cortical matter liquefies into the milky fluid, whereas the nucleus which is hard, sinks down. So some other type of cataract which we see is Christmas tree cataract, which is very uncommon. It's characterized by polychromatic needle-like formation, as you can see here in the nucleus, deep cortex in the nucleus. So the metabolic and the systemic insults will lead to different type of cataract, have some unique visual phenotype. So to describe like snowflake cataract, as we know, these are seen most commonly in diabetes mellitus patients. Then the oil droplet cataract that are seen in the galactosemia. Then Wilson disease, we see sunflower cataract. That is because of the chalcosis, copper alloy deposition, that often co-occurs with the KF ring. Then the myotonic dystrophy, we see the Christmas tree type of cataract. These are some of the similar I have described here. Let's skip this. So this is some anterior subcapsular plaque formation is seen. This type of cataract is often seen in the atopic dermatitis patients. And neurofibromatosis type 2 associated with early young adult posterior subcapsular capsular opacities. Now coming on to the developmental and congenital cataract, that is nuclear cataract, lamellar cataract, posterior polar cataract, sutural cataracts. I'll be describing through the picture. So the blue dot cataract, as we all know, is the most common one and associated with Down syndrome. Then the lamellar cataract is triggered by the maternal rubella and vitamin D deficiency during the peak metabolic activities caused by marked diminution of vision. Then the sutural cataract opacification is usually strictly limited to the sutures, Y sutures, or the inverted Y posteriorly. So this is often static and familiar. Secondary cataract, as we discussed, secondary to other causes like chronic anterior uveitis, acute congestive angle closure, and high myopia. So this is the posterior subcapsular cataract due to early uveitic posterior subcapsular cataract. Then this is the uveitic anterior plaque opacification. These are some of the other causes are due to trauma. So we see flower-shaped opacifies from blunt trauma, milky white snowflake-like cataract from electric shock, true exfoliation from intense infrared radiation. So these are some of the other secondary cataract like glaucoma flecken, extensive posterior cyanic anterior lens opacity secondary to uveitis, chronic uveitis. Now coming on to the clinical examination. So the important part is about the history taking. We'll have to take about the diminution of vision history, whether it was gradual, painful, glare and halos history, monocular diplopia, systemic history. Then the visual acuity testing, that is basically we have to see the visual acuity through the Snellen chart. Then light disturbance, whether the patient have any sensitivity to glare, colored halos around the lights or photophobia, color perception. Drug history we have to be taken essentially to note about the tamsulosin use and the anticoagulant to plan accordingly for the surgery. Then this have already discussed. We'll have to see the efferent pupillary defect also to rule out any posterior segment pathology, and ocular adenexa have to be examined properly to rule out any dacrocystitis, blepharitis to prevent endophthalmitis. Then as how we go through the slit lamp examination is cornea. We have to check for endothelial cell count. Any dense arcus has to be ruled out so that because it can obscure during the surgery. So have to be planned accordingly. Then anterior chamber, we have to see the depth. Shallow chambers increases surgical difficulty. Poor pupil dilation have to be seen before and plan accordingly. Then lens grading. So there are different type of lens grading which has been used by people frequently. So that I'll be describing later. So this has already been told. So the commonly now we use LOCS, lens specification classification system. So LOCS 2 is now not being used. LOCS 3 is the most quantity is the most used one now. So it's basically the quantitative assessment of the nuclear opalescence and nuclear color, cortical changes, and posterior subcapsular opacities. So this is how we grade according to LOCS 3 classification. Some other grading system which are used according to the color, that is grade 1 to 5, that is according to the whitish, yellow, amber, brown, black color. Then comes this is how it appears. Then comes the ERIDS clinical lens standard. That is basically nuclear standard grades the central hardening, cortical standard grades the peripheral wedge shaped opacity, posterior subcapsular standard grades the opacities at the nodal point. Then the Burato grading, that is basically the granular nuclear grading system from NO to N10. Then the other examination which has to be done before is fundus examination to rule out any pathology, posterior segment pathology, so that the visual expectation can be told beforehand. And B scan has to be done in dense cataract. Then sclera has to be checked especially in cases like high myopic patient and prior artery surgery, and prefer topical or subtenon anesthesia. Then refraction, any that is basically to plan accordingly for the IOL, toric or toric IOL and wound placements. And then the refractive surprise review result from the first operated eye to be adjust calculation for the second one. Clinical evaluation includes diagnostic biometry, keratometry, as you all know, axial length, IOL calculation accordingly. Then B scan, ultrasound, I have already told. So the importance of early diagnosis and management is basically to optimization of refractive outcomes, prevention of ocular emergencies like phacolytic and phacomorphic glaucoma, and restoration of quality of life. Early diagnosis allows for management with refractive glasses in initial stage, maintaining the patient's ability to perform daily activities before surgery becomes necessary. Thank you.
Thank you, Dr. Harsika, for summarizing almost each and every point. Now, I would like to invite Dr. Jagdish Rana sir, who is not well-known ophthalmologist, but also he is the important part of upcoming AIS annual conference at Ahmedabad. Sir, we
Yes,
need
sir.
your final comments.
Yeah.
On the
See-
first all, on the wonderful presentation by Dr. Harsika, then your inputs for the PGs.
Yeah, she did a great job, like while classification and clinical examination of cataract. Few points I would like to add or discuss. The grading of the cataract, rather classification, is very much important for the accurate diagnosis of this cataract, as well as to adjust the parameter of the phaco while planning the surgery to have a best outcome or the best possible surgical outcome of the surgery. So we can adjust the parameters of phaco as per the grading of the surgery, which is helped by the classification of the and grading of the cataract surgery. It also helps to have a anticipated challenges during the surgery. Say if you have PPC, posterior polar cataract or expository cataract, we can expect the jonular weakness, or we can expect a pre-existing PC rent also. So classification is very much useful to have anticipated challenges during the surgery, and we can prepare our OT anticipating the complication of the surgery. So that is I would like to add. Second thing is rather clinical examination. She has included almost all point, but few points I would like to add. That is the direct ophthalmoscope ray reflex is very much important, especially in a pediatric patient, where patient does not allow us to examine. Just by dilatation and direct ray reflex by direct ophthalmoscope can help us to see about the media opacity as well as the cataract. And on slit lamp examination, by oblique examination, by retroillumination, we can diagnose early PPC or early posterior subcapsular cataract, as well as retroillumination on AR. See, I have a habit that on each and every patient, whether patient is a pediatric or geriatric, on all patient, I check by retroillumination on ER. So even on a undilated pupil, we can diagnose the early lens opacity by retroillumination on ER. That is, I think she has forgotten to mention. And second thing, we have to be case specific. Say patient is having a trauma, we have to look for the sphincter tear, or we have to look for the vicious ring that can help us to anticipate the challenges that can happen during the surgery. As well as the second thing is when the vision loss is disproportionately higher than rather in comparison to the cataract which is seen on examination. In that case, we have to do the contrast sensitivity, which will usually help us to go for the cataract surgery or not. That is especially happens in a cortical cataract as well as early posters of capsular cataract. There's a point I would like to add. Rather than we can discuss more point. Yeah, there is a clinical point which I felt that during her examination, I like to add these points. Thank you. Thank you very much.
Thank you, sir.
Yeah, Dr.
Thank you so
Bhupeli,
much.
yeah.
Yeah. Anybody
Yeah.
want to say something? All right. Thank you, sir. Thank you for
Yes,
your
sir.
lovely inputs. Now moving on to the next segment, that will be investigations in cataract surgery, and that will be talked about by Dr. Karan Bhatia. I don't think he needs any introduction, but again, for the unversed, cornea, cataract, anterior segment refractive surgeon, visiting eye surgeon at Manaktala Eye and Maternity Home, Meerut, Drishti Eye Foundation, Meerut, Swan Jyoti Eye Hospital, Lucknow, and Shri Sai Nitralaya, Gorakhpur. He is Vice President UC, member AIOS Vision 2030 Committee, member Scientific Committee UPSOS, and Ambassador of Eye Foundation of America. The presentation would be discussed by Professor Vinita Gupta, who is the head of Pediatric Ophthalmology and Ophthalmic Genetics Division, Department of Ophthalmology in AIIMS Rishikesh, examiner for Royal College of Ophthalmologists London and the Royal College of Physicians and Surgeons of Glasgow, international advisor for the Royal College of Physicians and Surgeons of Glasgow. So over to you both, starting from you, Dr. Karan. All yours.
Yeah, is my screen visible?
Yes.
Yes.
Yeah. So I'll get straight into the topic before, so that I don't waste time. So yeah, the topic that has been allotted to me is the investigations in cataract surgery. I don't have any financial interest in the machines that I'll be showing. So why do investigations matter? So the image that you see of the lady over here is my mother who I had operated. I've operated both her eyes with a trifocal lens. So now the thing is, you look at the smile, and what patients nowadays want is, cataract is equal to refractive surgery. So patient expectations are high and the outcomes are judged in diopters. And the preoperative imperative is there. So therefore, the preoperative chair time and the investigations are very critical to minimize dissatisfaction and miss refractive errors. So coming to the topic, so basic and advanced workup is there, and the basic workup includes the best corrected visual acuity, the slit lamp biomicroscopy, which my colleague has very nicely described. The intraocular pressure, you want to do a dilated fundus examination as well. And the advanced workup consists of the optical biometry, the corneal topography, the macular OCT, and the specular microscopy. So you can add a ROPLAS or a syringing to it. The third would be the blood investigations, which are viral markers, a blood sugar, and a blood pressure, which are absolutely mandatory before you proceed for surgery. So biometry, it's the cornerstone for the IOL power calculation, and optical is the gold standard. I use the IOL Master 700, but various other platforms also give very good results. So the key parameters that you discuss in it are the axial length, the keratometry, and the anterior chamber depth. Remember the repeatability rule, that the repeat measurement if inter-eye axial length mismatch exceeds 0.5 diopter or readings are inconsistent. So coming to immersion and ultrasound biometry, as residents, you need to know this also. And sometimes in harder cataracts or in ocular surface diseases, or in case of when you're doing a transplant also in opacified eyes, you need to rely on immersion and sometimes contact as well. So the immersion is much more accurate than the contact, because contact compresses the eye and therefore it's less favored. So comparing these three, according to various studies, the optical biometry usually gives the longest axial length by about 0.08 or 0.09 millimeter longer than the immersion ultrasound, and therefore the immersion is slightly shorter than that. But the contact due to compression can underestimate amount how much you can calculate the axial length, and therefore it is there is also inter examiner variability in these cases. So it becomes a challenge to really rely on that. However, for dense cataracts, as I had mentioned, and ocular surface diseases, you need to sometimes go for the immersion and the contact. Coming to keratometry, keratometry is very important. So it gives you the values of your K1, K2, and your average K. And you have the role of the newer optical biometers, such as the IOLMaster 700 has the option of the TK, that is the true keratometry. So basically, this gives you the evaluation of the posterior segment as well. So astigmatism assistant is very important. And what I do is any diopter more than 1 or equal to that, I consider toric IOL. But if I'm doing a trifocal EDOF, that changes to 0.75. So if you have irregular astigmatism, you've got a corneal opacity or something, then you do not go for these EDOF lenses or a multifocal lens. So this is what a chart looks like. And these are the parameters that they have shown. It also has the CCT, the lens thickness, and you can put this in various formulas that like this and get your data. So this is the recent Vivity toric that I had implanted. So in toric, it gives you the access. You need to tell your SIA, and then you can plan your incision accordingly and then choose the appropriate model. This is the Barrett's toric calculator that is easily available for free of cost. So coming to corneal topography, so topography maps the anterior corneal surface and reveals patterns that the keratometry alone cannot detect. So therefore, when you've got a condition like keratoconus, so you've got irregular astigmatism or post-LASIK ectasia or a pellucid marginal degeneration or an opacity, it can really cause problems. So you can use topography. So something like this, if you see the axial map on this is a asymmetrical bow tie pattern. There's anterior and posterior elevation with area of thinning. This is the case of keratoconus. So therefore, you need to be very careful, particularly when you're planning a toric in this case, or a premium IOL. So here, ideally, this is the EKR map that is present in the Pentacam. If it's higher, you get a taller peak. That means that is good fit for a toric IOL. That means this is a regular astigmatism, and therefore you can implant that lens. However, if you get a flat graph over here, that indicates this is not a patient that is suitable for a toric IOL. Now, what are the red flags when you have variable keratometries, that is difference of more than 0.5 diopter between the sessions? You've got distorted Myers, you've got poor repeatability in the keratometry, more than 0.3 diopters particularly. That means you need to repeat the scan. Never trust a single scan, and reproducibility is the standard that you need to follow. Now, coming to osity of the macula, this is a very good thing that you can do, because sometimes even the best of eyes can miss subtle changes. So what you need to look for is an epiretinal membrane, and edema or a diabetic macular edema, ARMD, VMT. So a normal appearing fundus does not guarantee a normal macula, and subclinical pathology on OCT can significantly limit the postoperative vision and lead to patient dissatisfaction. So at least for your multifocal cases or the EDOF cases, you should be doing these scans. Next is the specular microscopy. Now, any count less than 1000, I'm talking about the cell density that you mentioned over here. This is, you need to proceed with caution and use dispersive OVT, high molecular dispersive OVT that have chondroitin sulfate, and minimize the phaco energy. Now, if a case like this, which has got Gaucher, this is Fuchs endothelial dystrophy, you need to be more careful with these things. And sometimes when the count is less than 800, you need to sometimes consider other options such as a SICS or an ECCE. So coming to lacrimal patency, most of us only just do a Roplas. Syringing, however, is the gold standard, and whenever in doubt, you need to do that. Treat first the dacrology part and then operate it. And there should not be any infection, because there's a risk of endophthalmitis in such cases. Now, coming to aberrometry and pupil dynamics. Now, high HOA, that is high order aberrations, can lead to a contraindication to your premium and multifocal IOLs. So therefore, wavefront aberrometry really helps. The pupil size matters. This is for the PGs. A larger pupil, more than 6 mm, increases the risk of dysphotopsia, glare, and halos with the diffractive lenses, whereas a smaller pupil, less than 2.5 millimeter, reduces the light throughout and limits the effective optical zone and the near performance. Now, this is an aberrometer. This is one of the machines that I use. This is got, so you can select the LOAs which can be corrected with glasses and the HOAs which cannot be corrected, and therefore you can choose your lens accordingly. So the red flags are significant coma more than 0.3 microns, a large angle kappa more than 0.5, a higher spherical aberration more than 0.3, and irregular astigmatism pattern. Now, nowadays, we are also using the artificial intelligence. This is one of the things that are there in my topography and aberrometry device. So it tells you, the newer model has got the EDOF as well. So it can tell you whether to put a toric or not. This is calculated on the basis of AI, whether to put a spheric or a aspheric lens, a multifocal or an EDOF. It tells you completely. It tells you the RMS. Any patient with have an RMS which is higher than 0.4 or something will tell you that this patient will have a good distant visual acuity. So this is how one of the patients, an unhappy patient, when I went for it, when I got the device later on, I went and saw that this patient, the RMS was actually quite problematic. It was on the higher side, and it has warned not to put a multifocal, which I had put earlier on. And this patient was very unhappy with that trifocal lens. Coming to the type of formula that you want to use, various formulas are available. This is the ones that I have gotten from the internet. However, we have also designed in UOC which formula to use. For the PGs, just take a screenshot of this. And I would say routinely we use the Barrett's Universal 2. And if it's not available, you can go for the SRKT. This is an online calculator tools that has been developed by Dr. Zain Khatib. This has got all parameters that I have discussed. All of this is a summary. From this is the link, and it's all freely available on the UOC website. And it helps to plan and do cases as well. Therefore, IL planning is extremely important. And what I would say is integrate all the investigations that I had discussed. The biometry, the topography, the OCT, the specular microscopy and aberrometry, and then customize the IL selection according to the patient, the monofocal or a toric or a EDOF or a multifocal, and the right lens is determined by the totality of the clinical findings and the patient lifestyle. And therefore, when you choose the right patient and get the right and put the right IL in them, you will have a better outcome. So the take-home points I would say is biometry is king, where accurate axial length and K readings are the foundation, and verify and repeat them whenever possible. Evaluate the cornea and the macula, and these are non-negotiable for premium cases. Never assume normality, and customize every case. No two eyes or no two patients are identical. Have an individualized workup, and this will give you consistent surgical excellence. And I would say that the best surgeons are not those who operate best, but those who plan best. So thank you so much. This is where I'm reachable and anybody can contact me. Thank you so much.
Thank you, Karan. It was a fantastic presentation. I would want to invite Dr. Vinita, ma'am, for her inputs on the presentation, and if she wants to add some more points to it. Ma'am, please.
Thank you, Bhuti. I would just like to add a few points. There was excellent presentation given by Karan. The only thing is, we first of all, especially as a baby nurse or even an advanced surgeon, whoever it is, a phacosurgeon, as he has rightly mentioned, every cataract surgery is now becoming a refractive surgery. So we have to correlate and be realistic with the expectations of the patient. Sometimes patients come thinking that cataract is the only cause for their visual decrease. So first thing, when you're assessing the patient, you have to assess whether the cause of his visual decrease is just the lens or is there something else. So, which is missed, like he has told about corneal things we take care of. The OCT takes care of the macula, even if we are not able to see the macula directly and maybe missing something which is not clinically visible, or the ultrasound, which we do when we have total cataracts. So we have to correlate, at least not in the total cataracts, where we may sometimes even have to do, like I'm talking about in case total cataracts, we may even have to resort to doing measuring the pupil reactions, which is very, very basic. Because sometimes patient may be having a coexisting glaucoma, like bad glaucomatous optic neuropathy sitting at the back, which in our Indian scenario is very, very common. That they have a glaucoma, they are not even aware of it. And they have a total cataract when they come to us, and they have expectations that they will have a vision of 6/6 next day with a total vision, complete, everything shiny the next day when they are operated upon. And when you see the fundus the next day after you have operated the cataract with a very good, clean surgery, and you find that there's a 0.9 cup sitting there. So that's what I'm saying, assessing the pupil reactions, assessing the IOP, and especially when you have a doubt in the other eye is not having a total cataract at the same time. Just a sec. Just. If the other eye is not having total cataract, it's also important to assess the CCT of these patients, the specular, the corneal, otherwise corneal assessment, the slit lamp examination. Even if you do not have a specular, at least try to do the zone of specular reflection. That gives you at least good enough idea. There is no gross abnormality with your corneal endothelial cells. And the second thing which I would like to add on is like one I think told was the correlation between the amount of cataract and the actual visual acuity loss which the patient has when he presents to you. Second thing, as Karan has mentioned about the premium IOLs, or maybe even for any IOL when we are implanting, what is the requirement of the patient? It's very, very important to ask for the professional needs of the patient, because many times we do not take, especially I'm not talking about maybe the private setup, you're more aware of it. But in government settings, people do not ask the profession of the patient. They just take every patient to be a routine patient coming for cataract surgery. So we have to ask whether the patient actually wants a monofocal lens or a multifocal lens, whatever. You just offering him, okay, we'll do this, but you're not aware of the expectations of the patient as regards to his professional profile half the time. So taking exactly what are his professional requirements is also very, very important when we are dealing with the pre-operative assessment of these people. And I think the premium IOL aspect, the biometry aspect has been very well covered by Karan. He has already talked about what all we need to do, especially with the Swepsos OCT biometers we have now. Even those OCT biometers, even if you do not do a proper OCT of the machine, it gives you a vague idea if something is happening wrong at the back of your macula. Even that time itself, you get a vague idea. And if you find something which is wrong in the OCT at that time, with the biometry machine itself, you can direct and take the patient for a dedicated OCT at that time. So that is one advantage. And even for early cases of cataract, like PSCs and all, where the patient may not be very symptomatic, when you're examining him, you may be having a 6/6 vision when he comes to your OPD, but he still has a PSC, which is very, very disturbing for him. So in those cases, glare testing, machines like eye trace, and all those things are also very useful if you have those armamentarium with you. I think rest is all I think been covered. And once you're probably an advanced surgeon, you can also start optimizing your own results, doing something called as optimization of your IOL powers. So which is like, we have the holiday formulas, we have certain other commercially available optimizers available by the Hills, as well as by Saurabh Sani, who has a DIO and a holiday, which are all paid tools. So otherwise, Barrett will work for most of the cases, and we have the SKRS tools which are available on the website. So all those cases will help. You need not stick to one formula, especially taking an average wherever you're in doubt. As Karan mentioned, whenever you have inconsistencies, take an average of the formulas. Take an average of the formulas. No single formula, whether it is short eye or long eye, average will always bring it as close to possible to your target as best. So that's all I say to conclude. Thank you.
Thank you so much, ma'am. Thank you so much for an in-depth analysis and input of yours. Now let's move on to the next segment, that is the cataract surgery, the management of cataract. It's only surgical. So for that, we have Dr. Hemanti Chaudhary and Dr. Sudipta Mitra, ma'am. So Dr. Hemanti Chaudhary will be presenting. She is the academic in charge and senior consultant in cataract and oculoplasty services of Chaudhary Eye Hospital and Research Center, Silchar, Assam. It's an NB accredited postgraduate institute of ophthalmology. She's a passionate teacher, an ace orator, and a prolific cataract surgeon. Dr. Chaudhary is the recipient of multiple awards and honors, including the prestigious K.R. Datta Award and AIOS APOS Vengala Rao Award. Ex-editor of Journal of Ophthalmic Research and Practice, she is academically driven and has publications in national and international journals. Discussing her presentation would be Dr. Sudipta Mitra, ma'am. She doesn't need any introduction. She is a senior phaco-refractive consultant in Calcutta, director of RMI Foundation, winner of multiple video awards on cataract and refractive surgery in regional and national platforms. Served as faculty in regional, national, and international platforms, serving as chairperson scientific committee, Ophthalmological Society of West Bengal. Over to you both, Dr. Hemanti and Sudipta, ma'am.
Thank you so much. Is my screen visible?
Not yet, ma'am. Yes, now it's visible.
Okay. Good evening to all. At the very outset, I'd like to thank Dr. Vibhuti and Dr. Sudipta for giving me this opportunity to be a part of this didactic lecture on cataract. And because this is a PG program, so I'll like to keep it very, very basic. In the next 8 minutes, I'll take you through to the management of cataract. I do not have any financial disclosure in this presentation. So this standard treatment workflow developed by the ICMR clearly states that the indications of cataract surgery are visually significant cataract, vision less than 612, or even better vision, but when patient has loss of contrast, other symptoms like glare and polyopia. For somebody who has a retinal issue and the visualization of fundus is important, he or she definitely needs a cataract surgery. A cataract with a narrow angle to improve the IOP also is an indication for surgery. Having said that, is there a role of medical management? I would say no. But when the patient is medically unfit and does not desire cataract surgery, you could give a refractive correction. So the types of surgery which has been in the history are the conventional ECC, which was replaced by the SICS, and then the more popular phaco, and finally we are in the era of femto laser-assisted cataract surgery. So this evolution of cataract surgery has seen a sea change right from the time of couching and now the flex. The anesthesia for SICS is mostly peribulbar. For phaco and flex, topical is preferred. For certain patients like pediatric, you might have to give general anesthesia. The pre-op preparation will consist of preoperative antibiotic on the day of surgery, tropicamide and phenylephrine combination for dilatation of pupil. To maintain intraoperative mydriasis, an epiphenetic informed consent has to be obtained. Proper painting with 10% betadine and nice draping is must for all cases. Now, the basic difference between phaco and SICS I'll be showing in the subsequent steps. But one thing which needs to be told is SICS is a very low cost and patient-friendly option, and it is not technology dependent, so it can be done in a wide range of cases, like in brown cases, in corneal compromised cases, vis-a-vis phaco, which gives a very good and excellent refractive outcome, as has already been mentioned. Now let us see some of the steps of surgery for phaco and SICS. This is the rhexis, as you see. In left side is the SICS rhexis, and in right it is a phaco-rhexis. The basic difference being the size of the rhexis, where in SICS you need a bigger size rhexis, and in phaco, 5.5 millimeter rhexis will do good. Coming to the incision in SICS, we will, in this case, as you can see, this is a black cataract. We are targeting a 7 millimeter incision. So a 3-planar scleral tunnel incision is conducted for an SICS, whereas in phaco, it is just either a uniplanar or a biplanar. In this video, you are seeing a clear corneal 2.2 millimeter incision. Moving ahead to the next steps for hydrodissection. In phaco and SICS, hydrodissection is essentially same, but the outcome that we desire is different. In SICS, we want the nucleus to prolapse into the anterior chamber, whereas in phaco, we want that the nucleus should have a very good rotation, but we do not want it to prolapse. Now, the nucleus delivery in SICS can be done with the multiple techniques. In this video, you will see a phaco sandwich that is being employed. The other techniques are the fish hook technique, irrigating vectors, visco-expression, or the Blumenthal's AC maintainer technique. Coming to the nucleus disassembly in phaco, in this particular case, as you can see, this is a total cataract. We have approached the case with a stop and chop technique. In this, first the central trench is being done, and then the 2 hemispheres are further chopped into smaller pieces, and then the smaller pieces are aspirated with the phaco tip. Here a 2.2 millimeter wound is used. Let us go to the subsequent steps like the cortical wash. Cortical wash in SICS is done with the Simcoe bimanual cannula. And in phaco, the right video that you see, it is being done with the bimanual irrigation aspiration. So the bimanual gives you the advantage of approaching also with the left hand, the temporal side. you can cover with the other hand. In SICS, the superior cortex can be taken out by introducing the Synco through the site port. Now, the final step of surgery, which is the IOL implantation in SICS, you can implant a rigid lens because the wound is open. However, in this particular video that you are seeing, it is a foldable lens. And in phaco, of course, the lens is injected with a cartridge injector system, and the incision will be anything between 2.2 to 2.8 millimeter. So finally, we have now the flex, in which we use femto laser assisted cataract surgery, wherein it is a very precise steps. Here you are seeing the capsulorhexis is being done. This is followed by the phaco disassembly. The nuclear segmentation is done by the energy of femto laser, and then the devising of corneal incision, the site port, and if required, in this case, you will note a limbal relaxing incision is being given, which can be done with femto laser. Now, after these steps has been done, the patient will have to be taken to the proper OT, where the rest of the surgery will be done with a phaco. So the journey of IOL has also seen a sea change right from the time of Ridley's generation 1 lens. Now, currently, we are in the generation 6 lens, and in the last 3 decades, there has been again a wide revolution in the lens, coming from blue filter, then the toric lens, the multifocal replaced by trifocal lenses, and finally the extended depth of focus lenses. So what these lenses are adding to the advantage of the patient, it is that we can give 6/6 vision, distant vision to almost all patients with this outcome, and also give spectacle independence, or rather reduced dependence of spectacle on almost 90% of your patients. So the key takeaways are, for cataract, surgery still remains the best treatment options. Technique can be phaco or SICS depending on the requirement of the patients. Betadine prep is must for all your cases. Post-operative steroid, cycloplegic, and 3 checkups are must. Timely surgery is the key. Thank you very much for your kind attention.
Thank you, Dr. Hemanti ma'am. It was a very detailed presentation and very, very crisp. Sudipta ma'am, your comments, please.
Yeah, thank you. At the outset, let me thank ARC, Dr. Vibhuti, Dr. Prashant, for Dr. Deepak for including me in this session. Dr. Hemanti has literally covered everything that is required for managing cataract by surgery. Yes, surgery is the only thing that we do for cataract. And I would just like to highlight for the younger people who are going to start surgery now. So for them, you have to optimize, as Dr. Vinita very nicely said, but you actually have to optimize number of steps. First of all, the time of surgery. It is correct that there are guidelines, but sometimes you have to follow the needs of the patient. If you have a thick posterior subcapsular cataract, even if the patient is seeing 6/9, and the optometrist comes and tells you might be seeing 6/6 part, but the comfort of the patient matters, and then you have to intervene. So you have to choose the time of intervention. Whatever you do, the patient must gain something after your surgery. This is very, very important. Obviously, for matured cases, you don't have to worry much. Number 2 is choosing the type of anesthesia. I would tell that in the early days, it would be good if you have a bit of uncooperative, a bit of a hyper patient, type A personality, that you do a bit of peribulbar anesthesia rather than go topical. It will give you more freedom, more stability in performing the surgery. And as you grow, you will know how to manage with topical anesthesia in all types of patients. Of course, in some patients, you still cannot manage if the patient is not cooperative. Thirdly, I would like to say the type of surgery has to be chosen very, very careful, very correctly pointed out by Hemanti. But in the initial days, it is better to learn SICS steps very carefully, especially the tunnel, the rhexis, the hydrodissection, because all these 3 steps will also matter when we do our phacoemulsification. And again, even if you go to flax, your hydrodissection will matter, and you have got a proper Rexis completion on flax or not, that will also matter. So it might be that is an incomplete Rexis that has been done by laser, so you'll have to complete your Rexis. So doing a Rexis starting from SICS is a very good practice, which will go a long way later in life, and it will reduce the learning curve for better technologies, for further technologies. Thirdly, when you're choosing a type of phaco machine, it is best to understand the fluidics. Each machine has their own advantage. Earlier, we used to depend on gravitational fluidics. Now we have all active fluidics. Everything is very nice, but you have to understand what works best in our hands. That is very important, because we need to deliver. We need to use the machine and make it friendly for us so that we deliver the best for the machines. So that is why there is a bit of learning curve, but before that, it is best to understand the fluidics of the phaco machine that we are going to handle. This is very, very important. Finally, the type of IOL, of course, I would prefer in the early stages that to do a monofocal to understand and keep the dissatisfaction low, then slowly mature to premium IOLs, because that again has a bit of learning curve. It requires a perfect Rexis. It requires a perfect centration. Every step needs to be perfect to deliver in a toric IOL, in a multifocal lens or with a trifocal lens. And finally, one point I would like to say, which we face very frequently nowadays, that is dry eye. Even after the best of surgeries, we have dissatisfied patients. So when I have just noted that through the before the management, we've seen the investigations, the clinical evaluation, everything was perfect. Please don't forget to look into the patient's eye for a dry eye. It actually makes a lot of difference, not only in the measurement, but also in the final outcome. Everything perfect, the patient might not be happy just because of dry eye. So just look into it, treat it, and then you can deliver the best. Thank you so much.
Thank you, Sudipta ma'am. With that, I was very well discussed. With that, we move on to the last segment of our webinar. So the speaker for the last segment, that is complications of cataract surgery, we have Dr. Sugandha as the speaker and Dr. Anup Chirayat as the discussant. So Dr. Sugandha has over 11 years of active clinical practice, routinely performing all types of cataract surgeries at a high volume center, including complicated cases and ocular trauma. Currently senior consultant and phacosurgeon, DNB faculty and surgical training in charge for PGs at Comtrust Charitable Trust Eye Hospital, Calicut. Also, phaco trainer for external candidates coming via Alcon PD program, co-instructor for several instruction courses on surgical techniques and wet lab practice at KSOS and National Conference AIOC. And Dr. Anup Chirayat, sir, is a phaco and refractive surgeon and medical retina specialist. He is an alumnus of the Arvind Eye Hospital, Tirunelveli. He was the first medical director of the Ahalya Foundation Eye Hospital Group in Kerala and helped set up the facility. Presently, he is the managing director of the Eye Vision Eye Hospitals, Thrissur, Kerala. Over to you both. Ma'am, first, please, the presentation.
Okay, I hope my screen is visible. Is my screen visible, Dr. Vibhuti?
Yes, ma'am. It's very much visible and you're audible. You can shoot.
Okay. First of all, let me thank the organizers of ARC for including me in this prestigious program of PG training. I am pretty thrilled to be here amongst such eminent personalities. And before I begin, I would like to thank my colleagues at Comtrust for their contribution of the lovely clinical photos that I'm going to be showing in my presentation. And so let's quickly get started. So for ease of understanding, I have divided the complications, in the intraoperative complications, into the ones encountered in SICS as well as in phacoemulsification separately. And I have placed a special emphasis on the complications encountered in SICS, because most of our postgraduates, in fact, everyone, starts their ophthalmic surgical journey with SICS. And then only once the hands are pretty set, they move on to phacoemulsification. So I will be showing more of SICS related complications, and in the end, just cap up with phacoemulsification. So, and also I have deliberately left out the anesthesia related complications due to lack of time. So let's quickly get started. So as it is obvious, the complications listed over here are mostly wound-related complications in SICS, and the issues, with a difficult delivery of the nucleus and iris injury and prolapse and so far and so forth. And in phacoemulsification, mostly it is, I have mentioned wound burn as the first one, but it's pretty rare, but it is definitely seen. And other more common ones are Descemet's tear, detachment, capsular excess related issues, either strafing and intraoperative floppy iris syndrome. And the later part of the table is pretty much similar. Let's deal with each one individually. So first we'll start with wound-related issues in SICS. So it is quite difficult for a beginner surgeon to understand the depth of incision. What we usually say as an ideal depth is a 0.3 millimeters, which is quite difficult for a beginner to understand. So what I would say is an ideal tunnel depth would be something that you can see the crescent pretty clearly through. Not extremely, but just this is probably an ideal tunnel depth. I hope it is clear in this picture. So if it is too superficial, like in this one, it leads to a buttonhole, which is shown by the arrow. So if it is too superficial, it leads to the buttonholing of a scleral flap, and the tunnel pockets might tear or cut through if the crescent is positioned improperly. And if it is too deep, there is always a chance of a premature entry into the anterior segment, anterior chamber, and consequently iris prolapse, Descemet's detachment, iris injury leading to hyphema. It just becomes a mess. And in phaco, mostly I would like to mention that a poor wound architecture, a port architecture, whether it is a main port or the side port, it is mainly a post-op wound leak, which we want to avoid, and which would potentially lead to a hypotony or an endophthalmitis in very severe cases, and if it is not recognized early enough. And wound burn, though, like I said, it is pretty rare, but we have recently seen some in our training cases. Over here, this is a tunnel cut through. I hope it is visible through the arrow. I would like to just quickly play this video to show a tunnel cut through because of improper placement of the crescent in a training video. Yeah, so I would like to just emphasize that in any surgery, if it is a compromised tunnel or a compromised wound, the main port or in phacoemulsification or the corneal incision in your SICS, you must always suture a compromised tunnel. That is, it is sort of like a thumb rule. Don't leave the patient with a compromised tunnel, because any amount of, even a small amount of straining would lead to, hypotony or wound leak and hypotony and the related complications in the postoperative period, which are pretty unpleasant and difficult to make the patient understand why such a thing happened. So then let's, okay, then we can move on quickly to capsular excess related. I think I had a few videos showing a difficult nucleus. Okay, we'll move on to that later. So right, so capsular excess related, it is like Dr. Haimanti very beautifully showed in her videos. The capsular excess related issues are, it is a pretty steep learning curve. So you need a decent size of rhexis to hydroprolapse your nucleus in an SICS. Whereas in phaco, you can go with about a 6 millimeter, 5.5 to 6 millimeters. In beginner surgeons, we recommend about to aim for a 6 millimeters one to be able to easily rotate and cleave the nucleus off the bag easily. In SICS, you can see in these pictures, the one on the left, there is rhexis extension and runoff, mostly because of the hypermature cataract, and there was a pretty intense intralenticular pressure. Whereas in the picture on the extreme right top, it is actually an SICS case. It shows a pretty decent sized rhexis for a phacoemulsification, but not in an SICS. I will be showing a subsequent video in which the surgeon was struggling pretty much, trying to hydroprolapse it and failing miserably, and ultimately that case actually ended up into a PCR and a nucleus drop. So a decent size rhexis, about 7 to 8 millimeters, would be ideal in a SICS case. So nucleus delivery issues through a tight or inadequate tunnel, and iododialysis if nucleus delivery is forced, a PCR during a hydroprolapse, like I mentioned earlier, or an undetected PPC as well during nucleus rotation if it was not recognized early enough in examination. That also leads to a PCR, or a PCR during the expression, a very difficult or forced expression. A zonular dialysis from excessive manipulation during rotation, nucleus prolapse, or delivery. So I'd like to quickly play this video in which you can see the surgeon struggling pretty hard to trying to prolapse this nucleus. It's just about a grade 3, but it is not possible to hydroprolapse through this size of rhexis. An ideal one for phaco, but not for SICS. So then, and this video will show you, just play this, yeah. So this one very clearly demonstrates a very difficult forced nucleus delivery, bringing the whole iris diaphragm out and with the iododialysis, and it just looks like a complete mess over here. So that other complications, of course, like a Descemet's detachment from use of blunt instruments can happen in both SICS and phaco, and excessive manipulation as well in the tunnel or during the nucleus delivery in SICS, and excessive handpiece movement in the main port. I have seen in trainee cases, just moving in and out too much without being aware of the excessive movement in the main port itself can cause the Descemet's to detach. And next is hyphema from bleeding in the scleral, the tunnel through the scleral vessels. An extreme case, nucleus drop, of course, is dealt by a VR surgeon. And of course, I would like to mention the IOL-related issues in phacoemulsification. SICS, not much, pretty decent sized rhexis. You can easily rotate the IOL in the bag. In phacoemulsification, there is a very characteristic IOL-related issues like a haptic break or a cartridge break or injector malfunction, or the haptic getting caught in the plunger of the injector. It is a pretty panicky situation for a beginner surgeon, but an early handover to a supervising surgeon or a senior would, help them to sail through that sort of tricky situation they land up in. And it is usually due to improper loading. So that can be avoided if the loading is done under the microscope by the surgeon themselves, rather than have the assistant do it for you. Oh yeah, so other complications like I've showed earlier itself, like iris prolapse, iododialysis, a worst case scenario of a nucleus drop. So I think that's about it for the intraoperative complications. I think Dr. Anup will be able to, pitch in with more, of his pearls. And I would quickly move on to postoperative complications now. So I have divided again into early and late situations. Early being so day 1 to 3. So you would have corneal edema. The first picture shows a very not a very alarming kind of edema. It is it should resolve in a sort of 3 to 4 days or maximum a week's time, and it usually happens due to excessive manipulation or retained viscoelastic. Worst case scenario in a Descemet's detachment, but you would know, the surgeon would know if there was any difficulty with the surgery and there was a Descemet's detachment. It would be seen intraoperatively, and of course raise the suspicion of DMD in a persistent corneal edema. You would have to go for an ASOCT to confirm it. Then a wound leak, wound gape, it would be acetals positive. A shallow AC could be with a low IOP or a high IOP. There are very good algorithms for the management of those in standard textbooks. So I'm not going to go into details of that because of lack of time. High FEMA, like I said, mostly from tunnel vessels. TAS is an early thing the PGs and all the beginner surgeons should be able to recognize and differentiate it from endophthalmitis. So I'm going to be placing a little more emphasis on this particular thing. So TAS, it is an acute, sterile, intense reaction to some kind of endotoxins or your viscoelastic or something that you have used intraoperatively. And it is very much characterized by intense fibrinous reaction and limbus to limbus edema, but there is a dramatic response to steroids. You must be able to differentiate it from endophthalmitis as PGs, because endophthalmitis, of course, has, as you know, it has a terrible poor prognosis if the patient has significant risk factors and it is not recognized early enough. So this tabular column shows the differences between TAS and endophthalmitis. I hope everybody, all the PGs can, just have a look at this, and it's pretty obvious. The early presentation and slightly delayed presentation, and the endophthalmitis is characterized by severe pain, lid edema, and marked reduction in vision. And it's the posterior segment involvement is always present, whereas in TAS it is absent. There is no, or usually none, no posterior segment involvement at all. Okay, so these are B-scan pictures to show the posterior segment involvement, intense vitritis in endophthalmitis. And so then we come to the next pretty rare postoperative complication, that is a choroidal detachment. Usually occurs in a case of undetected hypotenuse eye. If the wound leak was not detected, suddenly you would have this kind of a B-scan picture in choroidal detachment. The eye would be soft. So within week 1 to 4, early refractive surprise, I'm not going to go into details of that. As of now, I think with the present biometry algorithms, we don't get it that much nowadays. So there could be a persistent corneal edema, there could be retained lens fragments, or an endophthalmitis, cystoid macular edema, secondary glaucoma presenting anytime between week 1 to 1-4. So watch out for those. And more than 4 weeks to years, you would have depending on how benign or serious a condition is, according to that, I have that, place it in an ascending order. So posterior capsular falsification, patient is pretty, just a blur of vision. Patient doesn't have any pain or anything like that. So corneal decompensation, chronic CME, epiretinal membranes, IOL-related issues. I'm just going to show you pictures of that. Capsular phimosis, glaucoma, retinal detachment, and a pseudophakic bullous keratopathy. So just a few pictures to demonstrate. This very classically shows in an undilated pupil the PCO, again another PCO, and capsular phimosis leading to a tilted IOL and a new astigmatism. Subluxated IOL, of course, this, I don't know if the picture is clear. You can see the SCH, it is a traumatic one, a subluxated IOL in a traumatic case. Of course, if it could happen spontaneously in a case of pseudoexfoliation. Yeah, and an undetected desmus detachment, a long-standing one, could lead to pseudophakic bullous keratopathy and corneal scarring. And other complications like cystoid macular edema, I hope you can clearly see the cystoid spaces in the OCT macular picture, and a retinal detachment. Of course, the risk factors have to be taken into consideration. CME in case of an inflamed eye, or any kind of vitreous disturbance that occurred during the surgery, which would lead to traction on the macula and CME. And an RD in, say, a higher myope, and indirect ophthalmoscopy was not done, or maybe there was a poor view pre-op and it was not done post-op. So that also predisposes to an RD. So red flags to watch out for would be pain, redness, and hypopyon. It should be considered as an endophthalmitis unless proven otherwise. And sudden defective vision after weeks is usually sort of painless, RD or CME or IOL dislocation. So take-home messages to avoid complications. First of all, do no harm. And like Dr. Bhatia said, the best surgeons are the ones who plan best. So as PGs, as beginner surgeons, you must understand the importance of a diligent case selection, an effective patient or doctor communication. Make sure the patient understands the outcome from the surgery. Have a reasonable expectation. See, if there is a posterior segment involvement, you would have to communicate to the patient beforehand that the visual outcome is going to be sort of guarded. And of course, during the surgery, recognize a complication early and hand it over to a supervising surgeon. Ego must go is what I tell my PGs. So don't have any egos. Please hand over to the surgeon. Always think of the patient first. And of course, if there is a complication that happened, you must follow up the patient closely and impress upon the patient the importance of monitoring, post-op monitoring, in case there has been a complication. So thank you all for patient listening.
Thank you, Dr. Surendra, not for just summarizing all things, but you have shown with different videos and photographs that make more lively. Now I request Dr. Anup for his expert comment.
Hello. Yeah.
Yes, sir.
Yeah, good evening, everybody. First of all, I'd like to thank all of you organizers who have taken a lot of effort in coming out with this program. So, coming to my topic, Dr. Sugandha has actually covered quite in detail in the 8 minutes allotted to her. So, only some points probably which I can add is one is the case selection is so important, which again she had mentioned, because residents they generally they have a tendency to they select a very soft cataract. So because they always feel that soft is better, but we know as seniors that soft is not always good. So the ideal would be a grade 2 or a maximum of grade 3 for SICS. And then the case should not be having it should not be a deep set eye. It should not be a patient who is overweight with a short neck. All those things, no. So it should be an ideal patient for the to be selected for the resident. Then only they will be able to do good. And we always, nowadays, we tell our residents to start SICS temporarily. Because previously we used to tell them to start and then move temporarily. But now I think that the way to go is temporal because that is what gives the better visual results. Though it may be slightly more difficult because you don't have the brow effect of a superior rectus suture. And then the type of instruments, for example, the crescent blade. Generally, we give our residents the blades which are used once, used and after re-sterilized. That is because if you give them a brand new one, I have seen that many times they tend to create premature entries. And the premature entry is much more difficult to manage. So then we may have to, the trainer may have to take over the whole case. Because once you make a premature entry, the whole iris starts coming out and everything becomes a mess. So we give them a keratome which is used once so that at the most they can make a buttonhole which can be very well salvaged without causing much of a problem. The same way with the keratome also. Only thing is if a keratome, of course, it should be sharp. I think it should not be a reused one because if you use a reuse, the chance of detachment will be more. Again, the side port also, while entering with the side port, they should enter parallel to the iris, or either they go and hit the anterior capsule if they are putting too much pressure, or they may even hit the endothelium if they go in the other way. So that is about the section. And yes, the first section also, making the first external wound, because that is a matter of practice, because initially they don't know how much. Most of the time, they'll be just making scratch incisions. And if you tell them to be a bit more bold, sometimes they may cause a scleral disinsertion because through and through right up to the ciliary body. So it should be the ideal depth would be where you are just able to hold with your corneal forceps. So that is something only with practice you can get because unless you have a calibrated blade. So that is the external section. And the length of the tunnel in SICS, it doesn't really matter much. Even if your length is more, that's not going to cause much of a problem. But in phaco, the length, width, everything is important. Because if the length is more, definitely you will get overlocking, you will have corneal stripe, and visibility will be affected. So all those things would be a problem in phaco. In SICS, it will not affect much. Only thing probably the visibility. If you dissect too much into the cornea, the visibility part, especially in the subincisional cortex aspiration, all could be a problem. And a bigger axis, of course, is needed in SICS. Whereas in phaco, even a bigger axis can be a problem. The ideal, as Dr. Sugandha said, it should be around 5.5. But if you have small, that is a much bigger headache, because then the chances of rhexis tear and causing a zonular dialysis while you are trying to chop. Because many times in the beginning, there will be a lot of churning of the nucleus. So visibility may be an issue. And one other thing which I would like to add, practical thing, is the use of viscoelastics. Because I have seen juniors, they tend to overuse viscoelastic. Because your viscoelastic actually is a very, very useful and potent tool. But if you use it too much also, it's a problem. Because I have seen them overinflating the AC, and in SIC, what happens, the visco goes under the subincisional iris, and the iris keeps coming out. And they inject more visco, and it's like becomes a vicious cycle. So they should know what is the optimum use of a viscoelastic. When sometimes you need to go to the opposite end of the anterior chamber and start injecting the visco, especially before making the capsulotomy. Whereas if your iris is keeping on coming out, you have to inject it in the subincisional area so that you press down on the iris so that you flatten the iris. And sometimes you may have to use a higher molecular weight visco also, because if the iris is keeping on coming. And then another thing, like what Dr. Sugandha already mentioned, is that the recognition of a complication early. Well, that is what happens, is that if they have a PC rent, they should know or at least suspect that there is a rent or at least a vitreous prolapse. That is all those signs, classical signs that we say, the AC will become deep, there will be a clear area seen, and the rotation of the nucleus becomes a problem. So all those things they should look at actually. Whenever they have a doubt also, it is better that they call their senior. Maybe it may just be a false alarm. But then if they don't recognize it, it can lead to real big problems later on. So about the infection, and then they should always be taught, the residents, that any doubt in the integrity of the wound, they should suture. And if it's an SICS, it should at least be between at least 3 or 5 sutures. And in phaco, depends upon the need of the suture there. And managing a phaco burn, it's a very, very big problem, as we all know, because even suturing, sometimes you have to put so many sutures, and even then it keeps leaking. So I think with these few points, yeah. And then of course, there are a lot of other things also in complications, and like when they are, what type of technique to use in SICS in prolapsing the nucleus. Because many of the time, if you use a mechanical technique, you tend to keep on churning the nucleus, and that reduces the visibility. And in the end, you are left with a very misshapen sort of a nucleus, and you don't know where to hold it and how to bring it out. So, and some people use a bimanual sort of a technique, which again works out to be quite well. And in phaco also, the churning part of the nucleus is quite common in the beginning, because they will be just making, even if they are trying to chop it, they will be just scraping on the nucleus, and which will just loosen out all the superficial epinucleus and the nucleus, and that will again reduce the visibility. And then the nucleus is ultimately becomes sort of like a plate, and then neither are you able to chop it, neither are you able to crack it. So it becomes like a very difficult situation to come out of. So I think these are the few things, and which I would like to just add in this topic of complications, management of complications, cataract surgery.
Very true, sir. One thing, nowadays many companies are coming with guiders, means on the side port or the crescent, they created one more pointed, means they created in such a way that a guide is there for half of the entry of the side port. After that, it will become slightly more wider, so that the PGs can have a help or guide that yes, we cannot enter more than that.
Exactly.
That is the new thing which is coming. So for all, before going to thank you all, I would like to request all the PGs who are watching or their mentors, means for today, 3 hours is only left for the abstract submission for the midterm of the IAS. And for the annual, almost 1 month. I again request Jagdish Rana sir, kindly invite all the viewers to submit abstract and make Ahmedabad conference as big as possible. Sir, first.
Yeah, the AIOS is will be organized in February 27, 18 to 21. It will be at the Mahatma Mandir Convention Center in the Twin City, Gandhinagar, just near and just 15 minutes from our airport area. And the date has been already declared to submit the topics and TSTC courses by Dr. Namrata Sharma, our Chairman Scientific Committee. So I will invite all the speakers and all the attendees to register and as well as your submit your topics as soon as possible. And I invite all of you to visit our Ahmedabad and experience our hospitality, which will be unmatchable, and it will be, say, we will not have experienced this type of hospitality which Gujaratis offer to our host, Atithi Devo Bhava. So I welcome you all at Ahmedabad in February 27th. Yeah.
Thank you, sir. And just before thank you, we are planning our webinar in such a way that it covers the pan India. So today, whatever the topics me and Vibhuti decided, Vibhuti contacted all of you. Most of the time, people are asking why some from this page, from this page. You will see all the 4 zones: north, east, south, west. Just because we have a knowledge from all the pan India experts and the presentation from the everyone. That is the main aim of our EIVS-CRC, that we can reach everyone. So thank you all for accepting our invitation, given your precious time and guiding to lot of our PGs and the budding ophthalmologists. And thank you again from the whole team of EIVS-CRC to making it pan India too. Thank you everyone. Thanks a lot. Good night. Bye bye.
Thank you. Thank you. Good night. Bye bye.
Thank you.
Good night.